decision whether to over renal replacement therapy. This decision is very difficult. Not offering hemodialysis to all of our patients is a difficult decision, but renal replacement therapy is unavailable to the majority of world population with end-stage renal disease. In Egypt, we are lucky. We have our dialysis program since 1964, and our peritoneal program started 1997. In our university, in Mansoura University, we started our programs in 1989, and we have a new peritoneal dialysis program, which started with our eminent Nihal Atif 3 years ago. Due to ethical and religious beliefs, it is this decision, not offering hemodialysis, is a difficult decision. Making a decision to not initiate or to discontinue dialysis. Consider forgoing for AKI or end-stage renal disease patient who have very poor prognosis or for whom dialysis can't be provided safely. This include patient unable to cooperate, advanced dementia patient who pulls out dialysis needles, patient who have terminal illness from non-renal cause, patient older than age 75 years with 2 or more of these very poor prognosis criteria. Clinician response of no to the question. Would you surprised if the patient died within the next 6 months? High comorbidity index, significantly impaired functional status, severe chronic malnutrition. Medical management incorporating palliative care is an integral part of the decision to forgo dialysis in AKI, CKD, or end-stage renal disease. Attention should be given to patient comfort and the quality of life while dying. Management may include palliative care consultation and the referral to hospice program. And thank you.
Thank you very much,
Mustafa, very much for this brain stimulating lecture. Actually, we could gather from this lecture that there is no worldwide consensus. We're still too far from being in agreement on when exactly to start dialysis, and I think it will be something for individualized care, depending on the situation of every patient, situation on the place where you treat the patient, whether the dialysis is optimum or less optimum. And we've got a lot of discussion about that. But for the time being, I think we will leave the discussion to the end, and we will go further for our next step of the program. Thank you very much, Mustafa.
We can take 1 or 2 comments, Dr. Nagy, for Mustafa presentation. I just want to ask Amr and Peter about the decision, about the data Mustafa have presented, about the start of dialysis and hemodialysis. Actually, the data is very shocking because more than 16% of patients started hemo while they still have a good renal reserve. The GFR is more than 15 ml per minute. Do they started just for other reasons apart from the uremia or what?
I tell you, I don't know. I mean, if you look at every corner in any street, we have a dialysis unit. And I think, you know, this is the luxury of the abundance, in my opinion. I mean, I don't say that I'm practicing that way, but perhaps because it is so available and, you know, and it is financed and everything, I don't know if there is incentive to start. And I cannot speak to that, but obviously, this is something unique in the United States, the abundance of it and being covered by the government and being, you know, so available. And that is concerning. I mean, when you see Japan 6 ml or 5 ml and 15, I'm not saying that some of them, they really do need to start, I personally believe in the incremental dialysis, both for PD and hemo, and that's why we have Dr. Nagy, that we have for the other moderator that he just mentioned. That's why we don't have consensus, because really there's no answer, and every patient you look at it is an individual patient, and often for example, I start when the follow-up is not really to my liking. I'm worried that this patient is going to be lost. Those that have frequent ER visits with intermittent acute on chronic and then they recover, I know that one time they're going to be hit and there's going to be an immersion dialysis. So I lean to start them earlier than what I usually do. But I have tons of 5 ml polycystic kidney disease doing great, walking around and absolutely no symptoms. I don't rush into it. So I think still very, very individualistic. But to answer your question, I think the abundance of goodness and where I go, if I'm from Syria and I know I hear stories about them, how they beg person to they send them to the lab. They will dialyze them only if the potassium is more than 7. Chronic kidney disease, they are on ESRD. Only if potassium more than 7, you get dialysis. They beg the lab, please, they tell him, write that the potassium is 7.5 because my daughter is really dying. I mean, that it makes me cry when I hear stuff like that. This is just the other extreme. I guess that's what's in Congo also.
Thank you very much, Dr. Peter.
So, Dr. Sabri, I completely agree with Peter on that. It's we are taking advantage, I think, on our system, and sometimes it's very hard to treat and manage and follow up these complicated patients when they have late stage 4 or early stage 5. So maybe some nephrologists, they think it's better just to keep them on dialysis, and it's not only the responsibility of the nephrologist but also the whole dialysis team. But again, the majority of our patients are on dialysis or have advanced CKD because they are diabetic or have, hypertension. The spectrum and the cause of end-stage kidney disease in America might be different from other countries. So as you know, diabetic patients, they start early. They have, multi-system disease, and they have heart problem, volume overload. So maybe because these patients have, problem controlling either their blood pressure or their volume status. So that's another reason. By the way, the mean age of starting dialysis in America might be also very different from the mean age of starting dialysis patient in Egypt. I know that in Egypt, most of the studies that we have done, the mean age of the patient is around 40s or 50s, but in America, at least, they are 60s or 70s, either late 60s or early 70s. So the spectrum and the patient population are a little bit different. And even if there is 16% of patients start early, you don't know how many start late. So also on the other end of the spectrum, we have patients who starts dialysis late without really preparation for dialysis. They start with catheter as emergency dialysis. I don't know what is the percentage for that, but mainly
81%. And 81% start with catheter. Those are chronic kidney disease. They are not acute or chronic. Chronic kidney disease, 81%, and that number has not budged in 10 years.
That's 10 very years bad.
It's flatline. We start patient on catheter. I don't know what's in Egypt.
That's exactly what we need to focus on, how to prepare the patient. It's not exactly, it doesn't make very big difference if the GFR is 16 or 14 or 12, but how to prepare the patient so when he starts the dialysis, he is ready for it. He has, an access. We have multidisciplinary team and, a conversation about different modalities. We put him on a transplant list even before he reaches the end-stage kidney disease.
Dr. Ala, can I add one point?
Of course, Professor Samir.
Thank you, Dr. Mustafa, for your excellent talk. And from my side, I think it is very important to prepare our patients with end-stage renal disease for AV fistula if you will expect the dialysis within 1 year. Number two, so long as there is no difference in morbidity and mortality between early and late referral to hemodialysis, I think it is very important to put your patients under close monitoring and follow up, and put the patient away from dialysis as you can, so long as there is no uremic manifestation and no significant comorbidities for those patients. It is very, very important when you keep your patients as long as away from dialysis, so long as the patient is clinically okay and the laboratory is good. I think you can postpone your patient, especially with close monitoring, put your patient in low protein diet together with supplementary amino acids or keto acids. It is very important point. Number two, for regarding the hyperkalemia and the panic values, it is a way now to have culture that most lab they must report the panic values for all investigations immediately to the patient or relatives. It is very, very important to report this panic value to avoid unexpected mortality for patients. Thank you.
I agree with you, Professor Samir. I think Mustafa tackled a very important issues, the late referral, and the most important is the patient education. Most of our patients here are struggling to be away from the renal replacement therapy. And this is a very important issue because we are lacking a patient education actually. And this may be the difference between what the situation here and the situation in the States. We have a question from the audience, Mustafa. What is the strategy for diabetes to start hemodialysis?
According
Mustafa, can you unmute yourself, please?
according to the guideline, diabetes mellitus is a different issue. Patient with diabetes mellitus could start earlier than other patients. So we should follow up their clinical value. In some countries, they start above 15 for those who have severe proteinuria, has severe edema, has severe complication from diabetes. And they recommend earlier dialysis in diabetes patient.
Can I just comment على Mustafa? I a little bit
Sure.
disagree about that. I think diabetic patients will need dialysis earlier than the other patients, and there is no need to put special levels of creatinine or GFR to start dialysis with. But they usually will have symptoms earlier than the others. They might have some volume overload or uncontrollable hypertension or something else. But if they don't, I will wait with them and monitor them and see when I start dialysis according to the needs of the patients and according to the lab. And also, don't forget the level of care that the patient will be receiving from the local treatment or the dialysis center. If the level is good, then you might refer him earlier. If the level is not good, then you might wait. You might want to wait because dialysis might add morbidity and mortality more than no dialysis in those patients who are not very bad. I don't know if you agree with me about that. Back to you, Ala.
And also, let me just add one point, please, to make agreement here. Late versus early dialysis initiation is different from country to country. The criteria itself is different. So in the study, what was considered late in the studies might be considered the early in a country like Egypt. So we have to be careful when we manipulate the data and interpret the data here, because really when you look to the study, late is not late by the most of the countries standards, especially in the developing countries.
Okay, thank you very much for all of you. I think we should move to the next speaker. Dr. Samir, please.
Thank you, Professor Ala. From my side, it's my pleasure to join this very important scientific and informative meeting through cooperation between Kentucky University and Mansoura University. And it's my pleasure to meet my dearest and old friends, Professor Naga Abdelhadi, Professor Ala Sabri, Professor Amr Al-Husseini, Professor Hussam Al-Wakil, Professor Mustafa, and all our colleagues from Kentucky University. The second speaker now is Dr. Matthew Shea, General Nephrology in the Lake Cumberland Regional Hospital from Kentucky University, who will present a clinical case. Okay, Dr. Matthew.
Hello, everyone. Let me get my screen shared here. All right, are you able to see the screen?
Yes, we do.
Okay, perfect. All right. Again, my name is Matt Shea. I'm a nephrologist in Somerset, Kentucky. I did go to the University of Kentucky for fellowship from 2018 to 2020 and have been out in a private practice for the last 2 years. Our office is located about 75 miles south of Lexington in a town called Somerset. It's a lake community. It's a town of about 20,000, but the Tri-County area is about 60,000 population. And then we currently have 2 nephrologists here in our office. We have 3 dialysis centers and about 190 dialysis patients spread across those. So again, thanks for having me. And this is going to be an interesting case, hopefully. All right, so a brief outline of what we're going to talk about. Of course, we'll go through the case presentation, both the patient's hospital course as well as events that occurred at the outpatient dialysis center once she was discharged from the hospital. We're going to talk about dialysis membrane reactions, background, and some details regarding those. We're going to discuss the different available filter options we have as when someone has a membrane reaction, this certainly has to be considered, and potentially think about using alternatives if possible. We'll certainly talk about the various dialyzer reactions, a few other types of reactions that can occur with dialysis, and then a follow-up to our case. So with that, we'll dive down into the case. This was a 74-year-old female. She has CKD stage 3B at baseline, actually followed by another nephrologist, not our practice, in a surrounding town with a baseline EGFR in the 30 to 35 milliliters per minute range, hypertension and osteoporosis. She presented to an even smaller outside rural hospital with a several-day history of general symptoms, malaise, nausea, vomiting, and she was really focused on increasing lumbar pain around the site of a previous compression fracture and kyphoplasty. She had reported minimal oral intake due to these GI symptoms, not drinking much, not eating much. Once she got to the emergency department at the smaller community hospital, there was some concern, so she was ultimately transferred to our larger community hospital for further evaluation. Brief review of systems, no significant fever, no chest pain, no increasing shortness of breath, no rash, no urinary symptoms, and no NSAIDs from the history. Past medical history, again, CKD stage 3B, hypertension, osteoporosis for a 74-year-old, really not a whole lot there. Surgeries included kyphoplasty, cholecystectomy, and oophorectomy. She was a non-smoker, non-drinker. She lived independently, did all of her activities of daily living. Was a fairly healthy person, again, for age 74. And medications included lisinopril, rosuvastatin, thiazide, and others as listed. All right, physical exam. I actually did not see her initially at all during her hospital stay, but from the documentation, it looked to be fairly normal, consistent with anemia, which we'll discuss here in a second. Otherwise, fairly unremarkable physical exam when she presented. So initial laboratory data in the hospital, she had a normal white count at 7,000, was markedly anemic with a hemoglobin of 6.9 grams per deciliter, also thrombocytopenic with platelets of 114,000, azotemic BUN of 62, creatinine of 10.7, also acidotic and mildly hyperkalemic. Notably, she was hypocalcemic, even corrected for serum albumin, total protein listed there at 8.8. Synthetic liver function looked to be fairly normal, normal bilirubin, normal coagulation studies, normal liver enzyme levels. So after this workup, initially at some point there was concern for possible myeloma raised, so that serologic evaluation was ordered and probably took a few days to come back, but it ultimately did return with serum protein electrophoresis, immunofixation, revealing an IgA kappa monoclonal protein. Serum free light chains kappa was markedly elevated at almost 3,000. And she ultimately underwent bone marrow biopsy, confirming a diagnosis of multiple myeloma with marked plasmacytosis. She had a renal ultrasound that looked pretty okay, other than some decreased cortical echogenicity. She also had a bone survey performed as part of the myeloma workup, and again, multiple areas concerning and consistent with multiple myeloma. So it was thought that, on top of her CKD stage 3B, her myeloma probably contributed certainly to her acute renal failure and chronic renal failure, and she ultimately did require initiation of renal replacement therapy. She had a tunnel dialysis catheter placed while in the hospital and had 2 sessions of what I've been told of fairly uneventful renal replacement therapy in the hospital. Putting together this presentation retrospectively, I went back and talked to the dialysis nurses that took care of her in the hospital. They really didn't have any concerning findings, concerning events that happened during dialysis. Went pretty par for course, and she was ultimately discharged home with follow-up at the outpatient dialysis center, and of course with oncology to initiate treatment for her myeloma. So at the dialysis center, she came twice and had 2 further sessions of fairly uneventful hemodialysis. And then it wasn't until treatment number 3 that she really started having problems. And that's really going to be the focus of our talk today. Treatment number 3 started as usual, but within about the first 5 minutes, she developed marked hypotension, a diffuse skin rash, severe flushing of her face. She felt very nauseous, sense of vomiting occurring. She got a pretty profuse headache, and this, quote, sense of impending doom. She couldn't really just pinpoint exactly what it was, but she felt like the wheels were falling off and that she was going down the drain. So, of course, when all of that happened, the treatment was, of course, ceased, and her extracorporeal blood was not returned. The dialysis nurses did give Benadryl or diphenhydramine 50 milligrams when all of this happened, and had eventual return to normalcy within about 15 to 30 minutes is what I'm told. So this is a picture of our patient with the rash that developed on this first occasion. So as you can see, I'm not sure if you can see my mouse, but her face, her cheeks were markedly flushed, her ear is flushed. You can see on her upper torso and neck this urticarial rash that's developed, and this was pretty widespread across her trunk, abdomen, etc. This did abate or slowly resolve with time. I'm told this was still there when she went home, but it was definitely markedly better than when it first happened. So she was brought back to the dialysis center for an attempt at another treatment. Of course, with a lot of discussion between myself, the other nephrologist here in town, the dialysis nurses, to try to formulate a plan of what we were going to do. We decided to pre-medicate her with Benadryl this time, or antihistamine. We made sure to not use any heparin in case that might have been contributing to the reaction. We asked the dialysis nurses to thoroughly rinse the tubing and the filter for at least about 30 minutes prior to the treatment. Their standard protocol is only 5 to 10 minutes is what I'm told, but we asked them to do it for about 30 minutes. And then at the end of that 30-minute time, dump the saline that was in that circuit and then reflush with fresh saline to see if anything in the tubing, sterilant used in the tubing, might have been contributing to this reaction. Despite all this, unfortunately, the patient had a similar reaction to the first. Within the first 5 minutes, had an immediate return of the symptoms that we discussed, skin rash. So again, the treatment was aborted. We left the extracorporeal blood in the circuit, and the patient was discharged with a second attempt at dialysis that was unsuccessful. So again, after this, a lot of discussion occurred about best next steps. There was some collaboration with the folks at UK, some conversation with Dr. Sawaya. We decided to use a different dialyzer this time. So our dialysis company, Fresenius, they had a few choices we could use, but we chose a different dialyzer based on some experience of other nephrologists that have encountered this particular situation. We actually had someone there present during the initiation of this treatment to observe for ourselves what was taking place. This time we pre-medicated with both diphenhydramine and methylprednisolone, heparin-free, of course, again. We used a cellulose-based dialyzer rather than the standard dialyzer that our dialysis unit uses, which is a polysulfone dialyzer. But again, despite all of these measures, our patient unfortunately had the same reaction occur. I was not the one present, I was in clinic, but our other nephrologist was standing there at the chair side as this happened. And he said it was textbook classic type A membrane reaction, and they again aborted the treatment. And they held off on giving epinephrine. Her hemodynamics, her clinical picture fairly quickly improved, so they decided to hold off on that. But of course, this left all of our heads scratching about how to best manage this patient moving forward, as it didn't seem that hemodialysis was going to be a great option for her. So with that, we're going to talk a little bit about dialyzer reactions. Just a few of the definitions, terminology that we use when talking about these things. We can talk about first use reactions, reuse reactions. There are bradykinin-mediated reactions, of course, drug-induced reactions, typically with heparin or historically iron dextran, and then there are also fever and pyrogenic reactions. So just before we actually get into the reaction types, let's talk a little bit about our different available options for dialysis membranes. 4 main classes that I could find, the first one being cellulose-based. These are polysaccharide-based membranes based from pressed cotton. Not what we typically use first line here in the United States, at least, but it is an available option. Another category is substituted cellulose. This is some substitution of free hydroxyl groups. Most common of this one being cellulose acetate. And this is actually the type of dialyzer that we use. We use a cellulose triacetate dialyzer the second time. Cellulose synthetic, just like it sounds, synthetic material, and synthetic non-cellulose. So bigger category down here with a few more options. These are supposed to have increased biocompatibility, and that's typically what we use first line here, again, at least in the United States, with our standard one being a polysulfone-based dialyzer. But there are others, and a few acronyms to go along with it. Polyacryl nitrile, or PAN, AN69 for short, but this is acryl nitrile, sodium methylyl sulfonate, polycarbonate, polyamide, and this other one. All right, so a little bit of a few words on first use reactions. These can either be from the dialyzer itself, so the membrane inside the dialyzer, the tubing associated with the dialysis circuit, and the sterilization techniques used for the dialyzer or the tubing itself. Reuse reactions, historically more common than present day. And again, at least here in the United States, in my short experience doing nephrology over the past few years, I don't think I've ever had experience reusing a dialyzer. But this is typically associated with disinfectants that are used for dialyzer reprocessing. So the different options that are available for this include formaldehyde, glutaraldehyde, or peracetic acid hydrogen peroxide. With these types of reactions, they've actually identified IgE antibodies to formaldehyde in subsets of these patients that have had these types of reactions. And management is used a different sterilizer or a sterilant or disinfectant if you're able to identify that that's the cause. Single-use tubing and dialyzers have largely gotten away from, our experiencing reuse reactions though. So bradykinin-mediated reactions, these are classically seen with modified acrylonitrile dialyzers, or AN69 dialyzers for short. I know I at least had one board question on this for my nephrology boards, and it's when you're taking a angiotensin-converting enzyme inhibitor. So concomitant or simultaneous use of ACE inhibitors in this type of dialyzer can turn into a type A dialyzer reaction, which we'll talk about here in just a second. The mechanism is binding of factor 12 to sulfonate-containing charged membranes on the dialyzer itself. This ultimately leads to prostaglandin production, vasodilation, increased vascular permeability, hypotension, etc. All those classic symptoms we would think with anaphylaxis or anaphylactoid reactions. And this is because, of course, ACE inhibitors prolong bradykinin activity and they prevent the breakdown. So when we start to talk about dialyzer reactions, we really break it down into type A and type B reactions, with type A being the more severe form and type B being the less severe form. So I found this interesting kind of comparison that when we think about A, you can think about anaphylaxis. Type B, we think about boring. Not that they're boring for the patient, but certainly less concerning to us and those who take care of them than type A reactions. So a few words on type A reactions. They are extremely rare, thankfully. Saw one number quoted, 4 in 100,000 treatments of dialysis. So not seen very frequently at all. They are IgE-mediated acute allergic reactions. So same type of reactions that we're going to see with other types of anaphylaxis, whether it's from medications, bee stings, etc. Onset typically occurs very fast within the onset of dialysis, within 5 to 20 minutes. Our patient, every single time, is within that 5-minute mark. It happened extremely fast. Symptoms can include, they don't have to be inclusive, but they can include, so urticaria, skin flushing, respiratory symptoms, including coughing, wheezing, sneezing, GI symptoms, abdominal cramps, nausea, vomiting, and then of course hemodynamic issues, hypotension, can even progress to shock if it's severe. So if that were to happen, it could even lead to cardiac arrest. So certainly need to have a high suspicion for these if red flags are raised. And but other things to consider, we don't want to get pigeonholed and think this is it if there's something else maybe going on. So always keep in the back of your mind other things such as hemolysis, air embolism, dialysis-associated episodic hypotension, dialysis-induced hypoxemia, and dialysis disequilibrium syndrome. So the etiology is thought to be related to leachable substances from the dialyzers themselves or within the tubing, the circuit of the dialysis apparatus. Historically, these were seen with ethylene oxide, but it's now very uncommon for dialyzers to be used or to be sterilized with ethylene oxide. Dialyzers are typically, at least the ones that we have available, are usually disinfected or sterilized with gamma radiation. But ethylene oxide was historically used for dialyzers, and ethylene oxide is still used for tubing. The tubing that we have available at our dialysis centers are sterilized with ethylene oxide. This is where rinsing extensively it helps wash out any residual ethylene oxide that is present if that was the precipitator. Like we talked about, AN69 dialyzers with ACE inhibitor use, reuse of sterilized filters that we discussed, medications, so heparin and iron dextran, acetate, formaldehyde with reuse, and then of course latex. So we've got to make sure a patient doesn't have a latex allergy. Treatment, immediate cessation of the treatment, and this is very important, without returning the blood from the extracorporeal circuit. We don't want to return any cytokines, any immune response that had already developed that might be circulating around in the blood in the circuit. We do not want to give that back to the patient because that could only make things worse. So, you know, the dialysis nurses should be pretty well trained on that, but always good to emphasize that to them. You know, whether it's pre or post treatment, if you think it's going to happen, or if it does happen and you weren't anticipating it, you can give antihistamines, steroids, bronchodilators, and it can even progress to needing epinephrine. If these symptoms persist and are refractory, of course, you would want to get them to the hospital where they can be further evaluated. Prevention, so like we talked about, proper rinsing of the dialyzer and circuit. Again, we tried this extensively, at least 30 minutes. We even wasted the normal saline that was used in the first rinse. You can try reusing a dialyzer, avoiding AN69 dialyzers with ACE inhibitor use, gamma irradiation rather than ethylene oxide for the dialyzer, and again, pre-treating with antihistamines and or steroids. So a few words on type B reactions. Thankfully, these are much less severe than type A, but they are more common. So the distinguishing timeline is these are delayed symptoms, typically after 15 to 30 minutes, or even later in the treatment. Typical symptoms we associate with type B reactions include chest pain, back pain, nausea, vomiting, dyspnea. So similar to type A, but not as severe and not as rapid in onset into the treatment. Anaphylaxis can happen, but fairly rare with these types of reactions. And these actually improve with continuation of dialysis. So trying to distinguish if this is a type B reaction, pushing through the treatment actually may help the symptoms and get them through it. So we think this is complement mediated. On the dialyzer membranes, there are exposed free hydroxyl groups, and these interact with our complement system and actually activate the alternate complement pathway. This leads to a transient neutropenia followed by a bandemia. And I've got a chart here that outlines that fairly nicely. The neutropenia is thought to be due to sequestration of neutrophils in the pulmonary circulation. That's why it's thought that chest and back symptoms are fairly common because of that sequestration of all these white cells in the pulmonary circulation. And there is an increased association with cellulose membranes. So just a quick graph of the neutropenia and bandemia that occurs. Prevention is supportive, or I'm sorry, yeah, treatment and prevention, supportive care. Try to use the dialyzer if possible. Quick flow chart outlining these different types of reactions, and fever and pyrogenic reactions, always important to keep into consideration, but since I'm running low on time, I'm not going to get into the details of that. So our case follow-up, our patient transitioned to peritoneal dialysis. We didn't really want to attempt further treatments with hemodialysis given everything that happened. She had had one episode of peritonitis, so our question in the back of our minds is what's going to happen if we can't do PD any longer? Any questions or comments?
Thank you very much, Dr. Mas, for your excellent presentation. For case presentation and the discussion after this case presentation. I think it is very important points. You raised very important points. And nowadays we have a lot of advances in the dialyzers or methods of disinfection. And for the first time now, when ethylene regarding hypersensitivity to ethylene oxide, now there is a use of some materials in the hollow fiber which decrease the absorption of ethylene oxide, and so the priming of this dialyzer a good rinsing for this one can exclude ethylene oxide as a source. And also with the hydroxyl group of the cellulose unsubstituted matter, and now the hydroxyl group can be covered or substituted to another one, or substituted cellulose dialyzer. And the third one is the synthetic non-cellulose. Also, regarding you raise very important point اللي هو البراديكاينين reaction together with ACE inhibitor. So it is we will prevent the use of AN69 with ACE inhibitor because it can prolong the bradykinin and it can prolong these hypersensitivity reactions. Regarding the last point here regarding the bacterial contamination of the dialyzer or endotoxin contamination of the dialyzer, I think also it is very important because we must check the water treatment unit. And the number two, bicarb can flourish bacteria more, but we still using, we will insist to use the bicarb, and we must be correct a defect in the water treatment unit if there is allergic reaction, and to prevent the use of those patients high flux because it can lead to backflow of bacteria or endotoxin to patients. So it is very important. You raised very important points. Thank you for your excellent talk. And now for discussion, if there is any comment or questions.
Matt, I'm just curious. I mean, she had 4 treatments without reaction. Is that common for type A? I thought it is almost always the first time they touch the membrane. I mean, did she, responded like IgE were produced? She needed some priming to produce them or something?
Right, that was our thought. We thought that it was a first use or first scenario type reaction too, but reading a little bit about it, maybe there was some sensitization to something that she was exposed to and, just had enough time to produce antibodies to it. That was our speculation anyway.
Are you going to test her for, like, send her to an allergy specialist or something?
We haven't talked about that, but I guess that is a possibility. I don't think it's ethylene oxide because the tubing that we use for peritoneal dialysis also is sterilized with ethylene oxide. So I don't think that's it. It's got to be something else.
Yeah, but blood contact is not like peritoneal contact.
Oh, that's true. Right. Yeah.
And Matt, very nice presentation, by the way. Just a quick question. She has a multiple myeloma with plasmacytosis. Could be the plasmacytosis is the source of this bradykinin, cytokine, and histamine release, or you don't think so?
I mean, I guess, it is an elephant in the room that she also has that hematologic issue, and this has happened.
Because plasmacytosis by itself can present as a skin manifestation or systemic, allergic manifestation as well, because the main thing is the release of the cytokines, right?
Mm-hmm. Yeah.
Might be exacerbated
I
by
guess
her condition, might be by, inducing remission for her this with him in the future. Right, possibly, especially if PD runs out of being an option and she has to transition back, maybe that her myeloma is under better control, maybe that. Right, so I think because, at one point in the future, she might need again HD for any reason. So I think we have just to solve this problem.
Next time he's going to try it, he's going to send it to you, Amr, and you are going to
Good luck for that.
Mas, thank you very much. It seems a very puzzling case, actually. I just have some comment. Sometimes the physician actually cannot know exactly which causes this reaction, and we think with time that the dialyzer reaction is something of the past with the using of biocompatible membrane. However, nowadays there are many reports about dialyzer reaction even with biocompatible membranes. And this may be because of the addition of certain material like BD and bisphenol A, which increases the permeability of the dialyzer. However, this material can cause reactions. My question, what about the break test? It is suggested to do break test from an eluted material of suspected to be the cause of the reaction. Second, what about the other medications? I mean, ESA, heparin, iron therapy, this medication as well may be attributed? And my third question, what about her multiple myeloma? I mean, was she treated by bortezomib or high cutoff dialysis?
She's receiving chemotherapy for her myeloma. She was never, no high cutoff dialysis, no plasma exchange, anything like that. As far as medications, we intentionally did not put her back on the ACE inhibitor after that first reaction happened. And I don't even think she was actually taking it during the first reaction because it had been held with her acute kidney injury when she was in the hospital. And then as far as the tests that you're referring to, I'd have to read about that.
I see, I see. There are two questions from the audience. Rolo Asman is asking about the dialysate, the water treatment unit, the needles. All could cause reactions.
Mm-hmm.
And another question from Ben, could that be avoided by using plasma filters in the setting of multiple myeloma? He's asking if we can avoid the dialyzer reaction by using plasma filters. I don't know if he means plasma exchange or what.
Right, yeah, I'm not exactly
But she
certain.
needs dialysis. She needs dialysis, I mean.
Yeah, as far as the question about like the water supply, dialysate, et cetera, the unit is on a central water supply system. So it was not occurring in any of the other patients at the dialysis unit. And of course, they have their protocols that they instituted and double checked and triple checked all of those things. And they could not find any contamination of anything on the water supply standpoint.
I think you will be in trouble if she had multiple peritonitis attack. I don't know if she can cleared for renal transplantation from the oncology side or not.
Yeah, I don't think so. With being 74 in myeloma,
Yeah.
I think that's going to be exclusion criteria.
Yeah. Hopefully she will not develop further attack of peritonitis.
Yes, we're all hoping.
Also, Dr. Ala, if the source is water treatment unit, it will affect many patients at the same time.
Yeah, yeah.
If the source is a water treatment unit.
Yeah, you are right, Dr. Samir. There will be many cases, not only that case, that will suffer from the reaction. So should we move to the next speaker?
Yes.
If we don't have any comments, any further comments?
Okay, I will introduce the next speaker, and then Dr. El Wakil, our vascular surgeon here on the panel, will moderate the discussion of that particular talk. And I'm introducing Saeed Al-Ghasondaramuthi, and that's the only time I'm going to say it, or we go by Dr. A or Dr. Saeed, whatever you'd like. I've known Saeed since he was a medical student in India. He came to UK, to Kentucky, to spend 3 months with us. And he was really an impressive student back then. And then he went on and did his residency in internal medicine and then nephrology. I don't hold grudges why he didn't come back to us to do nephrology with us, because he really likes vascular surgery and he does like vascular interventions. So he went is a premier place in Wisconsin, University of Wisconsin, to be trained in nephrology, and they have interventional nephrology. So he spent 3 years. And let me tell you, when he came back to UK as a faculty now with us, of course we had to credential him. Saeed, I think he holds the almanac records of a renal fellow, the number of kidney biopsy a renal fellow has performed worldwide. He has that record, and I'm sure of it. If I recall correctly, Saeed was like over 60 kidney biopsy as a second-year renal fellow. That was really impressive. And you can see now the number of procedures he's doing right now at UK is incredible. So we have an experienced doctor now to tell us about vascular access, and particularly probably imaging and stenting and things of that nature, or tunnel catheters. Sai, I don't know what you have going to present your objective, but I will yield to Dr. El-Wakil to take it over.
Okay.
So, hello everyone. So, thanks, Dr. Sawaya, for the kind introduction. And yes, I started here about 9 years ago as a medical student under Dr. Sawaya. And yes, I went to Wisconsin and did my 3 years of interventional nephrology training. And I've been here back, and I'm the interventional nephrologist at UK. So my talk today is gonna briefly focus on hemodialysis access, and I'm gonna touch on the KDOQI guidelines that came most recently in 2018 and that was revised and updated for vascular access. The last one came out in 2001. So this was a much needed update that came out recently. And I'm gonna share some newer technologies that we have that are at our current perusal right now. And I think that would probably bring us to the conclusion of my talk. So
Sai, can you go to the display setting and mirror your screen? Go up on the display setting.
Got it, sir. Are you getting the right screen now?
You got it.
Okay. So I do not have any disclosures. So the objectives of today's presentation are threefold. Number one is to understand the importance of AV access in mortality and morbidity of ESRD patients. Number two is the strategy for AV access, and not just AV access, strategy for access in our CKD population, and what the updated guidelines from KDOQI say. And last one is, what is an ESKD life plan, and how can we as providers advocate for our patients in different aspects of this ESKD lifespan? So let's move on to the first objective, which is to understand the importance of AV access. So access in hemodialysis patients, I think our first speaker of today also mentioned the same thing, that access is directly proportional to quality of life in our patient population. Patients with AV fistula had the highest quality of life and highest patient satisfaction. So, and it's not just patients feel better. There's also an increased perception among patients that they feel better, that they are healthy, and it's not just the provider point of view, it's also that the patients inherently feel that they are healthy. And compared to patients with AV access, patients with tunnel catheters had lower physical functioning, had a lower sense of health perception, had a lower emotional role, as well as mental health scores. But the third point, which was published in JVA in 2019, which is the Journal of Vascular Access, it is kind of twofold. You have to look at it that patients who are more functional or who have a higher physical function are more likely to start with an AV fistula because they are more likely to show up to doctor's appointments, get everything done. But patients who have a catheter, who have a lower physical functioning and health perception, may just be with the catheter because they couldn't make those appointments, or they were sicker to begin with. And that is a caveat to the study where patients with CVC had a lower physical functioning as well. So moving on, this is just a graph that shows mortality of patients with incident access and their access over time. So the line with the triangle is basically catheter only, which is basically the lowest survival among all patients. And if the patients had a catheter and they got converted to an AV fistula or AV graft, that is about here, they still had a lower survival. The best survival was among patients who started with an AV access and they they had the highest survival among all these patients. And the interesting thing to note is patients who had AV fistula and AV graft at some point in time had required a catheter. They had almost equal survival. So the conclusions from these is patients with catheters or exclusively catheter dependent patients have the lowest survival among all patients. Patients who had exclusive AV fistula or AV grafts had the best survival on dialysis throughout the follow-up period. And catheter usage at any point during their dialysis plan decreased their overall survival. So not only that, if you compare catheter-related complications to a AV fistula-related complication to a dialysis graft-related complication, you would find that catheter-related complication has a more length of stay. They stayed for about 11 days total in the hospital, compared to 5 days for either a fistula or a graft. Their mean hospital expenses were higher for their hospital stay. And patients tend to be also, we also realize that our ESRD population, as they stay in the hospital, they're not getting their exercise, they're not getting their things. So this also leads to downstream deconditioning and all those things down the road as well. So patients with catheters do have a higher length of stay compared to other AV accesses, and they also have a higher cost of hospitalization as well. Now, if you compare, and most of the predominant population in the United States on dialysis are diabetics. So if you compare the risk of death due to cardiac issues by vascular type, access type, in diabetics and non-diabetics, you find catheters on top. So diabetic patients with catheters are likely to have a higher risk of death due to cardiac causes. And interestingly, however, though, patients with a graft infection for diabetics have a higher risk of death. So in diabetics, grafts, if they get infected, are not good, but catheters are absolutely bad when compared to them as well. Your fistulas are always better in diabetic patients. So, and last but not least, patients comparing vascular access type and hospitalization, you have patients with catheters are more likely to be hospitalized, and patients with catheters have higher deaths related to infections, and diabetics AV graft offers a worse prognosis compared to catheters. So to put it all this into perspective, we have a fistula, we have grafts, and we have catheters. And our predominant population is diabetics. And catheters are more likely to be infected. Sorry, I think it jumped a bunch. Yeah, catheters are more likely to be infected, and they're more likely to have a cardiac cause of death. But a graft infection is more likely to be deathly for a diabetic compared to a catheter infection. In other words, a catheter infection in a diabetic can be salvaged, but a graft infection is going to be more deadly. If a patient with a catheter is going to be they're more likely to be hospitalized, and they're more likely to spend more days in the hospital, and the hospitalization is also going to be expensive. And how much does it take to maintain these accesses? So this actually illustrates the number of procedures that are required per year that is required to keep these accesses functional. So the hospitalization for a graft or a fistula related infections were absolutely zero. And among the patients of 295 patients with fistula, they did require follow-up procedures during the years. But their comparative costs for the follow-up procedures remained much, much lower when compared to these small number of patients who had catheters, and their costs were much higher compared to the maintenance and the hospitalization required for any infections, for comparing AV access to catheters. So catheters, again, a higher cost just because of the hospitalization for bloodstream infections. But some catheters also need follow-up procedures as well. So it's not just the bloodstream infections. They also need, some catheters need follow-up procedures. But if you compare costs across the board, catheters are still worse. For example, we had 71 patients. The percutaneous procedures were 3,000, and the hospitalization was predominantly driven by the hospitalization for catheter-related bloodstream events, which was about $26,709 US. Now that we have dished catheters so much, how about AV fistula versus an AV graft? What is better? Is a fistula better or a graft better? So compared to a catheter and a fistula and a graft, we know that catheters are absolute worst. But comparing a fistula to a graft, a fistula has a primary failure rate of about 46.4%. It's different across different countries. If you look at the Japanese cohort or the South Asian cohort, the success rate of a fistula is about 80%. In the US, the success rate of a fistula is about 50%, which is a flip of a coin. So you have a really good patient who follows up, gets a vein mapping, really good vein, really good surgeon, creates a fistula, it's still a flip of a coin. Heads, the fistula works, tails, fistula doesn't work. The success rate of an AV graft is about 80%. In other words, the primary failure rate of an AV graft is only 20.6%. So our AV graft is destined to work 80% of the time. And the other thing to keep in mind is an AV graft requires only up to 20 days, which is roughly 3 to 4 weeks for it to get to maturity where you can cannulate. And this data is based on the old PTFE grafts from 2001. We do have 3 early cannulation grafts in the market right now where you can cannulate the graft within 24 to 48 hours as soon as the graft goes in. Again, there are certain do's and don'ts about these early cannulation grafts, but they are in the market right now and you can cannulate them as soon as they are in. So the time to adequacy, or the so-called maturation time for a graft, is almost non-existent in the present world. Whereas a fistula still has an adequation, have a maturation date of about 80 to 120 days. And we're talking about at least 3 to 4 months before you can start using a fistula. One of the things Dr. Savaya mentioned earlier in the conference was we do have a high catheter rate of about 81%. And if you actually break down that data to look at how many of those patients have had fistulas, I think there is a 30% of patients among those 81% do have fistulas that are in some stage of maturation. And there's also data that came out recently that for patients who are older than 60 and incident dialysis access, the patients who are more likely to start with the catheter actually have a fistula that's not ready to use. And they start with the catheter because their fistula is not usable yet, which brings into the question that we cannot predict when the onset of dialysis on these patients is. And when we place the fistulas, they're not ready and they need dialysis, and we place a catheter. And that's why the incident dialysis population on catheters is very, very high because of this time to adequacy, which can take 87 plus or minus 40 days, along with your 50% flip of a coin maturation rate. But the good thing is, if you get a working fistula, you almost never have to declot it. It almost seldom requires a thrombectomy, where the fistula is completely clotted and you have to open it back up. But you do require about a 0.38, which is a very, very low risk of angioplasties, very less risk of surgical interventions. But a graft needs its maintenance. You might have to declot it at least yearly. You might have to fix it. You might have to go plastiate at least twice a year. So you might have to do up to 2 to 3 interventions a year just to keep the graft functional. Again, the trade-off for a graft is you get the 80% maturity, you can use it in 48 hours, but you do need to maintain it with procedures, subsequent procedures throughout its lifetime. All right, there you go. Okay, so then what is the cumulative survival for an AV fistula and a graft? So let's say if we compare primary access failure, which is all including all accesses, there is no difference between a graft and a fistula. In other words, a fistula, the fistula has a 50% chance of not maturing versus maturing, but a graft has an 80% chance of success. So if you include all of those together, there is no difference between a graft and a fistula for up to 3 years. But if you exclude primary access failures, fistula is better. So in other words, a working fistula is always better than a working graft. But for all comers, a fistula and graft are equivocal if you have the right amount of tools and personnel to keep it maintained, to keep it open and maintain it for the course of the lifetime. And so we also have this dictum where how do you decide this? So if you have a patient who has a life expectancy probably of the next year, which is 3 to 6 months, I don't think sending that patient to a fistula creation is gonna be of any benefit, because a fistula at least takes 4 to 6 months to mature just to get usable. So that patient is gonna spend their time on the catheter, and they're not going to derive any benefit of placing an AV access. So you need to have a life expectancy of at least 1 year to derive benefit of placing an AV access. And the other thing you have to keep in mind is if your patient's life expectancy is about 3 years or 3 years or lower, a graft in that patient is actually equally beneficial as much as a fistula, because a fistula has a 50% chance of not taking off compared to a graft, which has an 80% chance of taking off, and you have the catheter out. And usually grafts can last up to 3 years easily, with and without maintenance, with maintenance even longer. So if your life expectancy trade-off is about 3 years, and you don't expect any further accesses, then a graft for that patient might actually be beneficial. And if the life expectancy is about 3 to 6 months, you don't even, for some patients less than 3 months, you don't even need to proceed with any of these AV accesses. For them, a catheter might be the best option. So in other words, what is the survival of AV access? So obviously, fistula survive the longest. So the 1 year survival of fistula is about 71%. And at 5 years is about 57%. So in other words, if a fistula survives about 3 years, it will survive the rest of its life. A graft at the max survives for about 3 years. It doesn't go, the 5 year survival of grafts is about 0% in that study. I have seen some grafts that have been surviving for a lot longer, like about 10, 15 years, depending on how we intervene and how much we take care of it. But mean survival of a graft is about 3 years. A catheter, a mean survival is about 276 days, and median is about 310 plus or minus 50. Again, in catheters, the survival depends on a lot of other factors, depending on what lock we are using, if the patient, how infections, other procedures, there's a lot that goes on with catheters. So in other words, a catheter usually needs to be replaced every year. A graft can survive really good for about 3 years. AV fistulas, if they pass the 3 year mark, they're not going to stop. It's a lifelong thing. Now that we have talked about all the different accesses and all their associated problems, the projected prevalence of ESRD patients is increasing as we speak. So what is that is access exhaustion is going to be a problem in the future. So what is access exhaustion? So we start with a fistula. If it fails, then you move up the arm. And then up the arm, you don't have veins that are superficial. You start using grafts, and then you start getting into these catheter-related central venous stenosis, and then you end up with a lack of hemodialysis access. Now, the other part of the puzzle is not just hemodialysis access. These patients need access to other stuff too. For example, if these patients are living longer and we find cancers in them, they might need ports for infusion. They get a really big bowel surgery, they might need TPN, which means they need a long-term line. Dialysis patients have a high risk of cardiac arrhythmias, which means that we need to place implantable cardiac ICDs or CIEDs with implantable leads. So access, and all of these are fighting for the same real estate, which is our central veins. And unfortunately, we just have two, one for the right, one for the left, and two for the groin. So if all of the catheters, the leads, the lines are going through the same central veins, we're just going to run into access issues where these veins are going to get stenosed, and we're not going to have anywhere to land access into. So access exhaustion is getting to be a real problem, because our prevalence of ESRD patients are increasing, and they're also living longer because we're actually delivering good care to them. So to summarize all this part of the talk, the first part of the talk, which is native AV fistula remains the best access. It survives for the longest. It is the cheapest. It is less expensive to maintain. It has lowest risk of infection, and it remains the best access. However, AV grafts are better than AV fistulas in certain clinical settings. Like the settings I described above, life expectancy of less than 3 years, have the reliable personnel to maintain AV fistulas, AV grafts. And again, a lower risk of infection, AV grafts perform better than AV fistulas. Catheters are the least reliable, or the least cumbersome. They're the least cumbersome, they're convenient, but they're very expensive. They're associated with the worst of outcomes, including infection, hospitalization, length of stay, and more problems down the road as well. And access exhaustion remains a major concern for our aging ESRD population. So how did the KDOQI, which is the Kidney Disease and Improving Global Quality Control group of our nephrology society, what did they do to address all these issues that we have? So the first vascular access guidelines by KDOQI were published actually in 2001. So they literally saw all of the stuff, all of the studies that were published, and they said, okay, AV fistula is preferred if your serum creatinine is more than 4, or creatinine clearance less than 25, or if you anticipate less than of RRT within a year, place a fistula. And you can only place a graft if you're not able to place a fistula or a failed attempt at a fistula. So that by definition became the Fistula First initiative, which was what was the driving force behind a lot of the fistula creations in the US in the last 15 years. So this was kind of the dictum by which everyone followed, and everyone had to have a fistula, and everyone, if they failed fistulas, then we went to grafts, and those were the rules. But then we have come to realize that not every patient is the same, and not every patient's life expectancy is the same, and not every patient can get the same access as the other person. We have patients who we start on dialysis at a very old age, and we don't expect them to live for more than a year. We do have patients who are very young, and we start them on dialysis for less than probably a very few months before they can get a transplant. We have patients who we can do other forms of dialysis, and they just need that as a bridge to something else. So we have come to realize that our patient population did not always fit into the dogma of fistula first. If fistula fails, a graft. If those don't work, then go for a catheter. We realized that there are certain NICE clinical settings where one is better than the other, and not every patient fits into this Fistula First initiative where a fistula can be usable in all of those patients. So what are the things that we need to consider for an optimal vascular access selection? The biggest thing is what is the ESKD life plan for the patient? So there are three major things that drive it. So the first one is what is their life expectancy, and along with it goes their age, frailty, comorbidities, and if they have any anatomy and failed accesses. So that kind of determines what sort of access that you want to pick for these patients. And based off of that, we have to kind of think about what is their life plan, as in their life expectancy, what all choices we can do as part of their life plan. And that includes transplant as well, because that includes transplant as well as part of their life plan. Because if you have a patient who is a great dialysis, who is a great transplant candidate, you absolutely do not want to use a grind catheter on these patients, especially on the right side. So there are, and you don't want to touch their leg veins to create any accesses and stuff like that. So even their transplant status, the peritoneal dialysis candidacy, all of that should be involved in planning that part of the discussion of their AV access. And last but not the least is you also have to consider what resources are available at your disposal, including your surgeon experiences, what are your institutional resources for declots, angioplasties, referrals, how quickly you can get to them, how many procedures and interventions you can do, and what team you have. So all of these things combine together to kind of form the optimal vascular access selection. And that's what Kedoki tried to do in their guidelines, which was published in 2018. So they should have the first guideline is the ESKD life plan. So they want all patients with progressive CKD who have a GFR of less than 20 should have an ESKD life plan, which is reviewed, updated, and documented. So we should have kind of a report that says what their plan is when their kidneys fail and how are we going about their plan. And the plan should not only include their vascular access, it should include if they're going to get a transplant, if they're going to be a candidate for PD, what is going to be their vascular access functionality, what is going to be their future access. And all of this should be done with the nephrologist, or in our institution, I do it. So it has to be kind of done with the patient. So we kind of have a plan not only for their incident dialysis, but all the things down the road. And instead of a fistula first initiative, so when you look at the 2001 guideline, it always said fistula first. Kedoki actually said it's reasonable to have an AV access in a patient requiring hemodialysis when consistent with their ESKD life plan and goals of care. So they kind of backed away from fistula first initiative and said not everyone needs a fistula, but if their ESKD life plan is consistent that they're going to be on hemodialysis for a long duration of time with a good survival, then they can have an AV access. And it can be a fistula or a graft. And they also move on to say that it is okay to have catheters. It is okay to have catheters in patients for a short amount of time for in certain specific clinical settings. But then they go on to say, based on all the data I showed you before, that it is AV access is always better, again, better than catheters at any point because of the lower infection risk, lower hospitalization, lower length of stay. But they also say the choice of AV fistula or AV graft is actually left to the operators and the clinician's best clinical judgment. So it's not just you have to create a fistula at all costs, but you can create a fistula or a graft with the idea that if you create a graft, you should be able to create a secondary fistula. So they've not moved away from creation of fistulas altogether, but we are trying to use a model where if we create a graft, we have the option to create future fistulas in the future. And again, based on other things, they say they're not able to determine if a fistula or a graft is better based on incident risks and stuff like that. And they also suggest if you're using a temporary line, it should be less than 2 weeks. And whenever possible, try to use a tunnel line instead of a temporary line due to the infection risk. And they also say that you don't have to convert from a CVC to an AV access just solely to reduce the mortality risk. And moving on, the last one, they also say that you have to also start vein preservation, which is what I'm going to talk about in the next couple of slides, where you start protecting the veins on the arms for when the GFR is less than 45. And they also say you have to be educated on all modalities of renal replacement therapy when the GFR is less than 30, so that you can start planning their ESKD life plan. Okay, I'm just gonna skip these slides because I think I'm out of time. So just to summarize all of the previous slides, we should start preserving veins when the patient's GFR is less than 45 or CKD stage 3B. A vascular access plan or your ESKD life plan should be in place when the patient's GFR reaches less than 30. And vascular access construction should begin when the GFR reaches 15. So the way I remember is preserve, plan, and construct. So when you're CKD stage 3B, you start preserving veins, which is basically asking the patients if they're right-hand dominant. Usually you want to create an AV access in the other arm and ask them to avoid getting any sort of big IVs in their forearm, because that's some of the veins we use for AV access. Many IV sticks in their median cubital vein. Do not use any PICC lines, no midlines, and try to save those veins. And not just peripheral veins, just also save the central veins as well. So don't get a pacemaker on the left side, like with the leads. Use a leadless pacemaker. Don't get an ICD. Try to do subcutaneous ICDs. So try to preserve the veins on the dominant arm when the GFR reaches less than 45. And that way, we have a really, really good chance of creating an AV fistula. Even if not an AV fistula, because there's no good veins, you can always create an AV graft in the forearm, which will help the upper arm veins to mature. And if the graft fails in 3 years, you can always convert it into an upper arm fistula. But if there's no veins, if you're going to start at the upper arm, then you don't have any more real estate to go up. And not all patients always need a vascular access. And depending on what their life plan and how much duration they have before, for example, if you have a 20-year-old ADPKD, no comorbidities, is getting a living donor transplant in the next 3 months, they don't need a fistula. They don't need a graft. You can just place a catheter, run them on dialysis for about 3 months, and they get a transplant, and you can remove the catheter, and they're good to go. But you have another 40-year-old has to stay on dialysis for the next 5 years, no living donors, needs a deceased donor kidney. PD is a great option. They can do PD for 3 years. We can construct an AV access by then. They can switch to HD when PD fails, or they can go to transplant. So ESKD life plan in protecting and preserving these accesses and falling them into, like, kind of lining them all up is what is needed. So just to summarize this, KDOQI updated guidelines, we need to have an individualized plan for access for every patient, which is called the ESKD life plan for every patient. And that should be updated every quarter. It includes all modalities, and we should focus on preserving veins, planning for the ESKD plan, and constructing access as needed. So the last part of the talk, I'm just gonna comment on what tools are available at our disposal. So as part of the ESKD life plan, like I kind of mentioned about, your options are intermingling each other. So you can move from AV access to PD, you can move back from PD to AV access, or you can go to transplant and you can remove the PD catheter and so on and so forth. But depending on the patient's survival, their cause of CKD, and how long they're going to need dialysis, you can move and switch between these modalities. That way you give the access the longest survival for your patient in that setting. An example would be if you have a very old, frail, about 80-year-old starting on dialysis with an expected survival of less than a year, I don't think a fistula would be available for him in that setting. PD would be a great option. So we can start him on PD, and then we can place a graft in him, because a fistula would take 4 to 6 months to mature, but a graft would be ready to use in about probably, if you use an early puncture graft, 48 hours. But if he has a poor vasculature, then we'll just keep him on PD. And when the PD fails, we'll just switch him to hemodialysis on a catheter. So there is a lot of movement among these plans, but having a plan in place will kind of help you transition among those moving targets. So just to summarize, we do have a lot more options for fistula creation at this point. So this is just these are all the different options of fistulas that are available now. So we always start from the lower down from the arm. So the classic snuff box or Semino AVF is your radiocephalic AV fistula, which is end to side of the cephalic to the radial artery. We can also do an ulnar basilic as well, depending on if you have an arm. And that's why vein preservation is key. If you have a patient whose arms have all been, these veins have been poked and for blood draws, IVs and stuff like that, if you don't have these veins in the forearm, then there's no way we can create these lower fistulas. And moving up, before about 5 years ago, we did not have any of these options. We just went up and went to the upper arm where we created a brachiocephalic or a brachiobasilic AV fistula. But because of the endovascular technologies available out now, we have the option to create an ulnar radial, or a perforator to radial fistula up in the elbow. And these fistulas are endovascular, so they don't have a scar. It just needs a perfect patient anatomy to do these. And of course, you need these perforator veins, which is the favorite vein for everyone for blood draws. So if you have blood drawn, which I'm pretty sure everyone, the most favorite vein for everyone to stick is the median cubital vein, which is because it's between the two heads of the biceps, it doesn't move and it's right there. But that is the vein that is required for these endovascular fistulas to work. So, and that's why vein preservation is key. Do not let them access that vein if you have a patient who's going to need dialysis in the next 2 years, because you take away 3 options for fistula creation. And the other important thing about preserving this antecubital is you can create a loop graft here, and that will mature both the basilic and the cephalic and sometimes the brachial. And these veins can be transposed to a fistula in the future day. And so that you're protected, you still have other options of fistula creation, secondary fistula creation up the road. So always start with lower arm veins. Perforator vein at the elbow is key for most of these endovascular, as well as the forearm loop, as well as your Grax fistulas. And you move up the arm and you have a cephalic and basilic. And so central vein stenosis. We do have newer tools for recanalizing central vein stenosis. Before, if you had an ipsilateral central vein stenosis, we used to say abandon, go to the other side. For example, a patient with right-sided catheter, we pull the catheter out, you cannot get into the IJ. It'll be abandoned, go to the left side, stick the left. And then after a few months, left side goes out, and then go to the groin goes out, transhepatic, translumbar, and so on and so forth. So, but then now you don't need to do that. If your right side is occluded, use the devices that are available. I think it's called Surfacer, which is basically a tool to recanalize occluded veins and get access to the exterior and place a catheter through the occluded system. Why is this important? Because you're protecting the other side. You have to kind of think that if you use a catheter on the right, you cannot get into the right and you go to the left. Now, if your right side is occluded, the whole of their head is actually draining to the left side. And you stick the left side and the left side gets occluded. Now, they cannot drain their head through your jugular veins. They're going to drain to the back. So you can cause SVC syndrome if the collaterals are not well developed, just by causing bilateral jugular catheters. So keep that in mind, and that's why we have these newer tools which are helpful in recanalizing these occluded veins and making sure we don't cause iatrogenic SVC syndromes. We do have hero grafts. Hero graft is a catheter plus a graft combination. So
we need to wrap up. We have one more case.
Just one more slide. That's it. I'm at the very end. So we have a graft which converts into a catheter, and you can just replace the recanalized vein. And we also have bioengineered devices, which are the human homografts, which are currently under clinical trials as well. Thank you.
Thanks, Dr. Saya, for your comprehensive presentation. I think you cover many topics regarding the choice in vascular access, the choice and planning of vascular access for end-stage renal failure, for end-stage renal disease. But I have some comments I would like to share with the panel. Number one, in your presentation, you said that the failure rate in native arteriovenous fistula reaches about 46%, and I think nowadays in good hands, this is a very high failure rate, and this is not accepted to have half of your arteriovenous fistula created closed or not maturated enough. Also, another thing about the time for maturation for arteriovenous fistula, you said we can wait for 3 to 4 months. I think if the fistula is not mature by 2 months, 6 to 8 months, 6 to 8 weeks, it will not maturate, and it should be considered an unmatured, and we should think for another method for closure of side branch, sharing the blood with the native vein or something like this. I think the proper way in planning yes.
So there are some scoring systems available to predict those. So this is just the average that is out there. Depending on proper hands, it can be better or worse. So the maturation had a huge mean. So it's like 80 plus or minus 40. So yes, a large amount of fistulas are ready by 2 months, but then when you're doing interventions, you can ligate, repeat scan, another 2 weeks, that adds to time. And that's why there is a huge variation. And we do BAMs as well, balloon-assisted maturations. And even with those, there is a study that was out there, I think 2 years ago, that says more than 3 interventions to get your fistula to prevent a primary failure, your patency is not that good. So there is downstream effects as well for those as well. Sorry to interrupt. It is a lot of topic that I just tried to condense. So that's why it's kind of all over.
I think the proper selection. I think the rule of the vascular surgeon is mainly to properly select which patient is going to have a native arteriovenous fistula and which patient will be better to have arteriovenous graft from the start. The proper planning is the best way to serve and to help our patients by clinical examination and by duplex. I think the preoperative duplex during planning, when the patient creatinine level, as you said, had reaches more than 4 or GFR reaching 30, you should start to plan for AV fistula creation for the patient. In this time, you should properly examine the patient, properly doing proper duplex scanning to have, if the patient have a good vein and a good artery, you can proceed for a native arteriovenous fistula. If there is not a good vein, we can proceed to arteriovenous graft. One point more I have to mention, and it is important because it is a point of controversy between us and the nephrologist. When we have a patient for the first time, we are planning for him to do a hemodialysis and he does not have a good vein, and the patient, we decided to do arteriovenous graft. The timing for doing arteriovenous graft differ. In patient with, we are planning to do arteriovenous fistula, it is better to do it early. We can do it 4 months, 6 months before starting dialysis, no harm. But in patient prepared for arteriovenous graft, no, it is just we need 1 month. It is a time calculated on the long time patency of the arteriovenous graft. So it must be done only 1 month before starting dialysis. We didn't need more time, we didn't need maturation time, and it is a time calculated on the patency and the duration of arteriovenous graft.
Dr. Al-Wakil, I don't think this is controversial. In fact, if we put a graph and we don't use it, we know it's going to clot. I mean, that's what I'm understanding.
Yes, but we didn't need to do it early. We didn't need to do it when the creatinine level is just 5 or 6. We should wait. We should wait until if 1 month before starting just 1 month before starting hemodialysis, not more. Another important point you have mentioned is about you said that in long-term follow-up, the patency of arteriovenous graft and arteriovenous fistula could be parallel. I didn't agree with you, especially in our locality. The infection rate in arteriovenous grafts in our locality, where most of our centers are present in rural areas, we have a high infection rate in dealing with arteriovenous graft. And in this situation, I think we have noticed, and I think all my colleagues from the Middle East agree with me, that the infection rate in arteriovenous graft may cut to going some backward, and we are not usually not going forward to do arteriovenous graft. We are not encouraged to do arteriovenous graft because of the higher infection rate, and that, of course, the long-term patency when we compare arteriovenous graft in our locality with a native arteriovenous fistula is not parallel anyway. In this situation, we exhaust ourselves in doing some unusual vascular access. We are doing something not doing in the Western countries. We are doing brachial artery to the brachial vein, which is the vena comitant of the brachial artery. We are doing some sort of transposed saphenous veins, the lower limb to the upper limb, to use a native vein. We are used femorosaphenous arteriovenous fistula in the lower limb. We exhaust ourselves as a vascular surgeon in our locality to do native arteriovenous fistula and to be away from arteriovenous graft, making them the last option. This is, I think, all what I need to comment about your presentation. Any question from the audience?
Thank you very much, Hussam, and thank you very much, Professor Sayi, for these comments. I'm afraid we are a little bit short of time, but anyway, we cannot ignore questions from the audience. We have a question here from Ben. He's asking, how do you maintain the graft? Do you wait for it to be dysfunctional or you act for? I think he's asking about surveillance of the graft. So, Professor Sayi, this question for you.
There are three things that you actually do for AV access: look, listen, and feel. Always look for any pulsations. Always look for any scabs on the fistula in the dialysis unit when we're rounding. Always look for any abnormal sounds that are heard. And then the two tests to do are augmentation test, where you create an outflow stenosis and see if the fistula augments. That makes sure your inflow is good. And then the other one is to do your arm raise test above the level of the heart and make sure the graft completely collapses. So if you do those and the graft is running fine, and we do have other devices down in the US called Vascularts, which measures access flows every time they're on the machine. And that's how we surveillance our grafts or fistulas. But a good physical exam for an AV access is really, really sensitive and specific for the problem. It's very poorly sensitive for central venous stuff, but for peripheral stuff, it's really good, very sensitive. So that's how you have to follow an access. And you have to intervene before it's thrombosed. The longer it's thrombosed, it's harder to intervene.
Thank you. If we move forward to the last, if we may, and in fact, it leads to what I just heard you saying. We don't say fistula first, but at least we do say no catheter first, and that is, I think, a mantra that should be ours. No catheter first, and then decide, look at your vein anatomy and what kind of surgeon do you have. And to talk about why no catheter, you showed us some good data, but I want, now here's Dr. Fawad, who is a senior fellow with us, but he's a unique fellow. He was a hospitalist for many years, and our program at UK is unique in the nation, where we have a hybrid program where you can spend half of your time as a hospitalist attending, and then half of your other 6 months as a renal fellow, to allow them mature. And these fellows, they come from conviction because they've been practicing medicine for years as a hospitalist, and they fell in love with nephrology. And that's why they come, and we love those fellows. Indeed, Fawad, we love you. So now Fawad's going to take a case of mine, in fact, that had really catastrophic infections that he will go very fast, Fawad. I'm sorry, but but you can go just to the main point and we can wrap it up. Go ahead.
Thank you for the introduction, Dr. Sawaya. I know we're running out of time, so I will try to go over my slides as quickly as I can. All right, so I'm going to talk about hemodialysis access-related infections, mainly focusing on catheter-related infections. I'll briefly present a case. This is a 69-year-old female with history of end-stage renal disease on hemodialysis Monday, Wednesday, Friday. She presented to emergency room on a Sunday after she was contacted about positive blood cultures. 2 days prior to her ER visit, she presented to her outpatient hemodialysis unit for her Friday hemodialysis session. At that time, she was noted to have purulent drainage from her TDC exit site. She also reported fatigue and malaise at that time, but she was afebrile and hemodynamically stable. So the decision was made to treat this on an outpatient basis. Blood cultures were obtained and she was started on IV vancomycin and ceftazidime. TDC removal was arranged for the coming Monday with interventional nephrology, but due to her positive blood cultures, she was advised to go to the ER on Sunday. Past medical history, apart from ESRD, was significant for hypertension, diabetes, systemic lupus erythematosus, for which she was on hydroxychloroquine, recurrent DVT, cirrhosis, morbid obesity, and hypothyroidism. On arrival in the ER, she was hemodynamically stable. She was ill-appearing, but not in acute distress. She had no murmur on heart auscultation, and there was clear purulent drainage from her right IJTDC site. Her lab workup did not show any leukocytosis, but her C-reactive protein was significantly elevated. So she was admitted to the hospital and started on vancomycin for MRSA bacteremia. Her tunnel dialysis catheter was removed and trialysis, which is a short-term non-tunnel dialysis catheter, was placed. She had persistent positive blood cultures for a week despite appropriate antibiotic treatment. ID recommended to add ceftaroline transiently to help clear her bacteremia. She had complications of septic pulmonary embolism, but her echocardiogram did not show any evidence of endocarditis. Eventually, the trialysis catheter was removed and a left IJ tunnel dialysis catheter was placed after blood cultures became negative, and patient was eventually released from the hospital with plan to complete 6 weeks of IV vancomycin with her hemodialysis. Apart from this hospitalization, she also had multiple other hospital admissions due to dialysis access malfunction and infections. She previously had an AV graft placed, which was complicated by poor healing incision, eventually got infected and required AV graft takedown. This was further complicated by wound dehiscence with long healing time. So with that, I'll talk about tunnel hemodialysis actor-related infections and why do they matter. In the United States, approximately 80% of patients initiate hemodialysis with a tunnel dialysis catheter. Data from the US renal data system shows that this has not changed much in the whole decade from 2009 to 2019. And approximately 20% of all prevalent hemodialysis patients continue to use tunnel dialysis catheters for maintenance hemodialysis. Dr. Mustafa Abdul Salam and Dr. A already talked about the poor prognosis associated with central venous catheter-associated hemodialysis. I'll just briefly quote some more figures. The frequency of hemodialysis catheter-related bloodstream infection has ranged between 3 to 6 episodes per 1,000 catheter days, which corresponds to an approximate incidence of 1 to 2 episodes of bacteremia per catheter year. Incidence of bacteremia is approximately 10-fold higher in patients with tunnel catheters compared with patients who have AV fistulas or grafts. And catheter-dependent hemodialysis patients have a 2 to 3-fold higher risk of infection-related hospitalization and infection-related death compared with patients undergoing hemodialysis on an AV fistula or graft. The main infections associated with tunnel catheters are exit site infections, tunnel infection, and catheter-related bloodstream infection. Infectious Disease Society of America defines exit site infection as hyperemia and duration or tenderness that is confined to the 2 centimeters from the exit site. It may be associated with fever and purulent drainage from the exit sites, and it may or may not be associated with bacteremia. A tunnel infection is defined as a tenderness, hyperemia, and a duration that extends beyond the 2 centimeters from the exit site along the subcutaneous tunnel, and it may or may not be associated with bacteremia. Coming to catheter-related bloodstream infections, the main risk factor is prolonged use of catheter. A study of 472 patients showed that hemodialysis with a tunnel dialysis catheter infection was seen in 35% of the patients at 3 months, 54% of the patients in 6 months, and 79% of the patients by 12 months. Other risk factors include previous bloodstream infections, iron overload, immunosuppression, Staph aureus, nasal carriage, and hypoalbuminemia. The risk was not significantly associated with patient age, sex, race, diabetes, vascular disease, heart failure, or catheter laterality. Gram-positive organisms, including Staph aureus and Coagulase-negative staph, are responsible for almost 40 to 80% of the cases. Gram-negative organisms are involved in 20 to 40%. 10 to 20% are caused by polymicrobial infections, and less than 5% are fungal infections. Fever and chill is the most reliable clinical feature to suggest catheter-related bloodstream infection. Concomitant exit site and tunnel infections are present only in 5% of the patients of catheter-related bloodstream infections. Other signs include hemodynamic instability, altered mental status, catheter dysfunction, hypothermia, nausea, vomiting, and generalized malaise. So treatment strategies for catheter-related bloodstream infection can be categorized into systemic antibiotics, antibiotic locks, and catheter management. And management decisions depend on clinical presentation of the patient, the microorganism isolated, and the vascular exit options of the patient. So in all cases, we obtain blood cultures and then initiate broad-spectrum antibiotics, which should cover both gram-positive and gram-negative organisms, including MRSA and Pseudomonas. The recommended broad-spectrum antibiotics that should be started empirically are vancomycin, a loading dose of 20 milligram per kilogram, plus ceftazidime, which is 1 gram immediately after HD. For patients who are allergic to vancomycin or has a history of vancomycin-resistant enterococci, daptomycin can be used instead of vancomycin. For patients who are allergic to cephalosporin, gentamicin can be substituted for ceftazidime. After obtaining blood cultures and starting empiric antibiotics, we should see if the patient meets criteria for immediate catheter removal. These include persistent hemodynamic instability or severe sepsis, evidence of a metastatic infection, or exit site or tunnel infection concurrently with a bloodstream infection. Talking about antibiotic lock solutions, so if the patient does not meet criteria for immediate catheter removal, the catheter should be treated with antibiotic lock solutions. Basically, they are a combination of concentrated antibiotics and heparin, which are instilled and retained into the catheter lumen at the end of each dialysis session. Antibiotic lock solutions are designed to kill bacteria present in the biofilms that are adherent to the catheter lumens, potentially eliminating the source of bacteremia without catheter removal. They are used as an adjunct to systemic antimicrobial therapy under the catheter is replaced or when attempting to salvage the catheter. So the contents of the antibiotic lock solutions are changed to match the systemic antibiotics given. So if you're starting vancomycin and ceftazidime empirically, the antibiotic lock solution should also contain the same antibiotic. But after culture results, after you're de-escalating the antibiotics to vancomycin alone, then the antibiotic lock solution should also only contain vancomycin. The success rate of antibiotic lock solutions in curing a catheter-related bloodstream infection were highly dependent upon the infected organisms. For example, success rate was approximately 90 to 100% with gram-negative infections, 80% with Staphylococcus epidermidis and Coagulase-negative staph infections, 60% with Enterococcus infections, and only 40% with Staph aureus infections. And due to this low success rate with Staph aureus infections, many experts will proceed with removal of the catheter in patient with bloodstream infection to treat these organisms rather than attempting to salvage the catheter. In patients with gram-negative or Staph epidermidis catheter-related bloodstream infections, the use of antibiotic lock therapy frequently allows for continuation of hemodialysis through the infected tunnel catheter without catheter exchange, thereby limiting the number of procedures for the patient. So for definitive catheter management, most patients will respond to IV antibiotic therapy administered concurrently with antibiotic lock, will have clearance of bacteremia, and these patients can have their catheter exchanged over a guide wire once they have notable clinical improvement after 48 hours of appropriate antibiotic therapy. However, catheter removal rather than replacement over a guide wire is recommended if patients have persistent fever or bacteremia 48 to 72 hours after initiation of appropriate antibiotics to which the organism is susceptible, or when the infection is due to difficult to cure pathogens such as Staph aureus, Pseudomonas, Candida, other fungi, or multi-resistant bacterial pathogens. A new tunnel catheter should not be placed until after blood cultures are negative in patients who have catheter-related bloodstream infections due to Staph aureus in Canada, and preferably for other infections if feasible. In patients who do not have an alternative site available for catheter insertion, catheter exchange over a guide wire or catheter salvage might be considered instead of catheter removal, regardless of microorganism isolated. However, this should only be done in extenuating circumstances when there is extremely limited options for hemodialysis access. So how do we triage patients who have suspected catheter-related bloodstream infection in an outpatient dialysis unit? All patients should have blood cultures collected and empiric antibiotic given. And then we should see if the patient meets criteria for immediate catheter removal and referral to the hospital. And these include concurrent exit site infection or tunnel infection, suspected metastatic infection like osteomyelitis, endocarditis, epidural abscess, etc., or persistent hemodynamic instability, sepsis, despite infusion of IV fluids. If the patient does not have any of these indication, and they can be treated in an outpatient setting with continuation of IV antibiotics with hemodialysis along with antibiotic lock. And then catheter exchange can be performed once the patient has received appropriate antibiotics for 48 hours and the presenting symptoms have resolved, except for Staph aureus in Canada, in which case we should actually wait for negative blood cultures before exchanging the catheter. If the patient has any of these indications, then of course we refer them to the hospital. In these cases, the catheter should be removed and the patient should be continued on IV antibiotics. And again, the catheter should be, a new catheter should be placed only after the patient has received appropriate antibiotics for 48 hours or more and have the presenting symptoms have resolved. So for antibiotic management, for uncomplicated catheter-related bloodstream infections, which respond quickly to empiric antibiotics, there is no evidence of metastatic infection and they are hemodynamically stable. They should be treated with 3 weeks of appropriate antibiotics and 4 weeks in case the organism is MRSA. For complicated catheter-related bloodstream infection where there is hemodynamic instability, persistent fever, or bacteremia despite appropriate antibiotic therapy and evidence of metastatic infections like endocarditis, epidural abscess, or osteomyelitis, these patients should receive tailored antibiotics for 6 to 8 weeks. Again, for catheter management, catheter salvage is reasonable in uncomplicated catheter-related bloodstream infection where there is rapid improvement after empiric antibiotics, there is no hemodynamic instability, and no evidence of metastatic infection. Catheter should be removed if patient has complicated catheter-related bloodstream infection where there is severe sepsis, hemodynamic instability, concurrent evidence of tunnel or exit site infection, persistent fever or bacteremia, and resistant pathogens. And in complicated catheter-related bloodstream infection, a catheter exchange can be attempted if the patient is afebrile for 48 to 72 hours after starting tailored antibiotics, hemodynamically stable after treatment initiation, and no evidence of tunnel or exit site infection if there are limited vascular access options. Now talking about exit site infection and tunnel infection in the absence of bloodstream infection. For exit infections, culture should be obtained from the drainage of the exit site, and they should be started on empiric antibiotics with gram-positive organisms. The modified antibiotics regimen once culture and sensitivity results are available, and usually treated for 7 to 14 days. For tunnel infections, blood culture should be collected along with drainage of the exit site. Catheter should be removed without exchange over a wire and insert a new catheter in a separate site. Of course, they should be treated with broad-spectrum IV antibiotics to cover both gram-positive and gram-negative organisms. And usually the treatment duration is 10 to 14 days. How do we prevent hemodialysis catheter-related infections? Avoiding catheter usage whenever possible, and preferentially using an AV access. Strict adherence to sterile technique when handling the catheter. Routine use of antimicrobial locking agents to prevent infections are not recommended, but selected patients may benefit from this approach. Exit site antimicrobial agents was initially thought to be a good strategy as it appeared to decrease the rate of bacteremia, So there is a there's a definite risk of emergence of resistant antimicrobial resistance. Despite this risk, both CDC and a joint working group led by the Society of Critical Care Medicine and Infectious Disease Society of America recommends the use of povidone iodine antiseptic ointment or triple antibiotics ointment at the exit site after catheter insertion and at the end of each hemodialysis session, provided the ointment does not adversely interact with the catheter material according to manufacturer recommendations. Regarding Staph aureus decolonization, the optimal role for active surveillance culture is not known. Active surveillance cultures appear to be most useful in the setting of hospital outbreaks and among patients at high risk for MRSA carriage. Now, a few words for AV graft infection. The risk factor for AV graft infections include pseudoaneurysms, hematomas often due to inappropriate graft cannulation, severe pruritus and scratching over needle sites, and manipulation of excess during secondary vascular procedures. Infection may be local, not involving the graft. It may involve the graft, or it may be systemic. Localized puncture site infections without any systemic signs can be treated with topical or oral antibiotics until clear. All other infections require IV antibiotics and a surgical consultation and may require graft segment explantation with bypass or a total graft explantation for bacteremia, infected thrombi, or anastomotic insertion. These are my references.
Thank you very much. Obviously, we are short on time, but that was nice, Fawad. And what I would like about it is I'm pretty sure Amer and Dr. Sabri will have those slides available to our audience because they are all full of guideline and straightforward algorithms that may be very clinically helpful for us when we are practicing. One thing we learned from this case, you got pus coming out, you get that catheter out and don't wait about anything. And whether it's Friday or not, and I've learned it the hard way. And the reason poor lady, she's been infected so many times that, you hate send her to the ER. But anyhow, you have the guideline. Dr. Ala Sabri, please let us know about the future, what is next for us. And let's do the quiz.
Thank you very much, Fawad, for this interesting case. As Peter said, we are a little bit short of time. So please, Iman, go ahead with the result, please. Iman, are you ready?
Yes, Khaled. The answer of the quiz.
Could you stop sharing, please, Dr. Fawad?
Oh, sure.
My screen is the KDIGO guidelines. The KDIGO guidelines recommend the referral for benign renal replacement therapy in people with progressive chronic kidney disease with 10 to 20% risk of kidney failure within. Nearly half of the responder selected 12 months, which is the correct answer. Bradykinin-mediated dialyzer reactions are associated with ACE inhibitor use, and this type of dialysis membrane is 30% of the responder selected the polymethyl methacrylate, while 27% selected acrylonitrile sodium methylsulfonate, which is the correct answer. Type B membrane reactions are the most selected answer was complement mediated, which is the correct answer. Type A membrane reactions are treated with the most selected answer was all of the above, which is the correct answer. Referral of pre-dialysis chronic kidney disease patient for dialysis access creation should occur when glomerular filtration rate is nearly half of the responders selected 15 to 20 milli per minute per surface area, which is the correct answer. Vein preservation in chronic kidney disease patient should start when glomerular filtration rate is than most answer was 30 milli per minute per surface area, while only 15% of the responders selected 45 milli per minute per surface area, which is the correct answer. The KDIGO considers it is reasonable to use non-tunnel internal jugular catheter only for temporary purposes with a limited time period of Nearly half of the respondents chose less than 4 weeks, but the correct answer was less than 2 weeks. Thank you. Dr. علاء. Dr. علاء.
Yes, Iman. I just want to remind the audience to complete the course evaluation form. Iman will share the link, and please feel free to evaluate our course because this will improve our next course. Before closing the event today, I would like to announce that our next meeting will be 4 months later from today. So it will be the last Thursday and Friday. It will be 24 to 25th September because our 12th.
It will be in
Sorry.
November, right?
Yeah. Amr, our conference will be in September.
Right, your conference, but our course will be in November.
Yeah, it is 2 months after. Thanks for the correction. I would like to invite all of you to our 12th International Mansoura Nephrology and Dialysis Center conference. These are the moderator of the conference. We are very happy to have many guest speakers. Of course, Amr Husseini will be with us, Professor Peter Sawaya, Professor Michael Winkler, and Professor Iman. Can you move the slide, please? And Professor Intisar Hidayah from Morocco, and of course, most of the eminent nephrologists all over Egypt. And the course will be 3 days. The first day, which is 28, will be in Mansoura, and 29 and 30 September will be in the lovely city of Porto Said. Before I end, I would like to thank all the speakers and the moderators, of course, from the American side, Professor Amr Husseini, Professor Peter Sawaya, Professor Johnson Webb, Professor Myrna, Professor Sayi, and Fayed and Matt as well. From the Egyptian side, Mustafa Absalam, Mustafa Anis, غادة السعيد, بروفيسور الشحات, بروفيسور أيمن حماد, بروفيسور حسام الوكيل, بروفيسور ناجي عبهادي, and also the heroes behind the scene, the director, Mona, Dr. Mona and Dr. Aman. Thank you for all of you, and inshallah waiting to see you after 4 months from now. Thanks again and goodbye.